Oh, thank you very much for inviting me here. I am pleased to be able to talk with you. And I need to let you know that I do not totally speak for CDC, so I'm speaking for myself. But I do want to share with you a little bit about what's going on at CDC and our current approach and why we're doing some of the things that we're doing. Now, CDC is a huge, big place, and it addresses public health across the entire United States, all of the full breadth of things. And they have a number of large programs. And one of our goals is to integrate MECFS into the basic mainstream of public health. And so there is something called the Behavioral Risk Factor Surveillance System, BRFSS. And this was established back in 1984, and it is now active in all 50 states and 3 territories, and it's a phone survey of adults. It collects data on health-related variables, chronic health conditions, and use of health services. And the key thing about this is the data is available at the state level, and local data really prompts local action. It gets people's attention. And the website has areas of more information. And so, as you may know, that one of the basic questions of public health always asks is, how many cases are there? How big of a problem is this? And the studies that we've done to estimate the prevalence and the burden of MECFS have been based on a very few population-based studies that cover very limited areas of the United States. These studies are very expensive and time-consuming to conduct, and we really can't do these on an ongoing basis. And there's never been any nationwide or state-level based information on the prevalence, the number of cases, or the burden of MECFS in the US. And so what we would like is a sustainable way to identify prevalence trends. Everybody would like to know what's happening as time passes. The other advantage of integrating into the behavioral risk factor surveillance is that MECFS can be related to other topics that are covered by this survey, such as access to health care, quality of life, physical activity, health status. And we could easily, by linking the data, identify comorbidities and factors that influence MECFS. So our program first presented this suggestion to the 2013 BRFSS conference, and at that time it did not receive the number of votes. The way you get a question into the survey is that you do a proposal to the organization. If your proposal is accepted, then you give a presentation at the meeting, and then it's discussed. But the proposal did raise interest among some health departments, and it raised awareness of MECFS. And 5 states decided to include questions about MECFS as a state option. There are like different size modules, and the states can choose to add some questions. And Alabama, Connecticut, Kansas, Nebraska, and North Carolina added these questions. 3 of these states then continued to ask the question. And so we presented again this proposal in the 2018 BRFS conference. And we're really excited to be able to tell you that this was approved. And MECFS was accepted as what's called an optional module. Now, an optional module is not one of the core that's given everywhere, but it is a defined set of questions, and it makes it very easy for the states to include it. So what do you think made the difference? What do we think made the difference that made this accepted in 2018? Well, one is persistence and increased familiarity with MECFS from the prior conference and the booths and the talking that we've done. But what also made a difference is advocacy support. Lily Chu and ME Action did a program called Call to Action, Urge Your State Health Department to Track ME. And so what we found was that a number of the state health departments actually came to the meeting already primed, ready to find out, well, what's going on and what is this about? In addition, at this presentation, we were able to provide preliminary results on what we found about MECFS from the state-added questions in the 2014 and 2016 surveys. And so I'm going to give you a little brief information on what we did find out. And this is from an abstract that's being presented at the Council on State and Territorial Epidemiology Conference in June, that's being held in June. Now, one of the strategies that we have is to try to present MECFS at as many different public health conferences as we can in order to get the message out. So in these 5 states, over those 2 years, there were a total of 54,000 people that responded. It was a slightly older age group, mean age of 58, and of the respondents overall, 42% were female and 80%, more than 80% were white. So what we learned was that 1.6% had ever been diagnosed by MECFS. And of those that were diagnosed, 81%, almost 82% were female. And of course, this fits with what we know about MECFS. And of those that were diagnosed, about 70% still had the diagnosis. Now, what's interesting is that the prevalence estimates of MECFS in these states are very similar to those that were found in Canada using a very similar survey mechanism. So we think that this is good evidence that the survey is working. We also found that 78% of the persons reporting MECFS still had function in at least one area, functional limitations. And again, this is what we would expect: difficulties concentrating, walking, dressing, bathing, doing errands. And 83% had 2 or more of the 11 chronic health conditions that are tracked in VRFSS. And I think overall, it's underappreciated how many additional illnesses persons with MECFS actually have and how difficult it is to cope with. While access to healthcare was pretty good, almost 90% had insurance, and 90% had at least one healthcare provider. However, despite this, there was still a barrier in receiving care, and 36% didn't receive health care because of cost, and only 16% had received a routine checkup within 2 years. So we have additional plans to increase surveillance. Now, the way that the government works is that we have proposals, we put them out, and we see if we can get people to want to do the work that we're suggesting. And so I can't promise that these are going to happen. These are what we would like to do, assuming things work the way we would like. And that is, we'd like to establish an active surveillance in schools. And the reason that we think schools would be a good place is that MECFS is sort of the #1 cause for chronic school absenteeism. And the schools are right on the ground right there. And the schools need to know about MECFS. And so through this surveillance, it'll be both, we'll get some information about the numbers of cases, as well as an opportunity to educate the schools about what MECFS is and what the children need as far as educational support. We also would like to tap into the Vaccine Safety Data Link project. And this is a project of integrated health systems that have been brought together to collect data to follow what happens in response to vaccination programs. And we would like to start with case finding in one of these systems, actually come up with an electronic record algorithm to identify MECFS cases. And this is a first start. This is what's needed first in order to start trying to look at whether there is any linkage of MECFS with vaccines. And so our requested activities is really to define a case definition and validate it. And I don't mean a new case definition, I mean an electronic algorithm definition of identifying cases. Verify that it'll work, and then we'll go forward from there. Both of those projects, while we think they'll start at the end of this year, would be ongoing, and it would take a number of years to come to fruition. Now, CDC recognizes that improved healthcare is really the #1 problem that we need to address. I mean, other than finding the cause and the cure. But meanwhile, people are ill and they need care. And so we've been working on our web pages to incorporate the recommendations of the IOM report. And in 2016, we held a roundtable meeting where we had stakeholders come to help us refine the message. And when I say stakeholders, this was a really important meeting for us because we had all different points of view represented. We had medical educators, we had medical experts, we had patients, foundations, the whole works, everybody that had something to say about ME/CFS. And the exchange of ideas was really very important. So we based on the feedback, we launched our material for the general public last June, and we updated it this May, and our healthcare provider section should be posted in June. We also have planned a Medscape activity, which will involve 4 experts in ME/CFS, and it's a way, Medscape in the US is a free online service, and they're very good at promoting medical education. We also plan to have another roundtable at the end of 2018, again, continuing the stakeholder engagement project to really focus on what sort of materials will be most effective and used by healthcare providers in caring for their patients and trying to get the message out. And so we're really focusing on a lot of the medical professional organizations, as well as bringing patients in to help be sure that they can say what they want their doctors to know about this illness. We have plans to work with one or more of the professional organizations, and we think that our proposal will be approved and accepted, and if that works out, it could be a model for working with other organizations. And these medical professionals, like the American Academy of Pediatrics, they can conduct continuing medical education events for their members, webinars, and put articles in their chapter newsletter. And that's really getting the medical professional groups to extend and amplify the message is important. So I want to talk just briefly about one of our other big projects, and that's the multi-site clinical assessment of ME/CFS. You may have heard about this because I've been talking about it for a while. It's an ongoing project, about 5 years. And it was an opportunity for CDC to work with experts, clinical experts in ME/CFS. And the unique thing about this study design is that we relied entirely on their clinical expertise for identification of patients. And that's the only way that you can collect data to generate a sort of empirically defined case definition. Now, we haven't gotten there yet, but we did share data with the IOM, which I'll show you. So the other key thing about this is that the patients were enrolled from multiple practices in the United States. And we had some really basic questions, collecting data on how the clinicians each diagnose and manage ME/CFS. And then we wanted to collect standardized information on all of the illness domains. Just really quickly, and I'm not going to do justice to all of these 7 clinics in the interest of time, but they are all recognizable experts in the field, scattered over the country, and working with them has absolutely been a pleasure. We've learned a lot. We also used this platform to add on additional studies where we did some cardiopulmonary testing. We did cognitive testing both before and after the exercise challenge, and worked with CogState, which was a group that has come up with online testing, simplified, and if we can come up with simple measures that could possibly be clinically. Okay. So this is one of the findings. It's just basically the symptoms and the percentage of the patients that have them, and you can see the order and the severity is as we expect. And this data was shared with the IOM committee when they were developing their diagnosis. So this is an ongoing study, and the data is being used. We are enriching it with additional patients. I want to get to one other thing that we've done is trying to standardize the physical examination, and focusing on the NASA lean test, which has been called a poor man's tilt table test. And we think that it'll be a tool for clinical use. We've worked on trying to standardize it, and we're looking for objective signs of abnormality that clinicians could look for in their patients in their office. And it's basically a change in heart rate and blood pressure with standing but leaning against the wall to avoid using the legs. And then finally, one of the main goals of MCAM was to enhance measurements of ME/CFS to improve understanding. And we wanted to refine the phenotypic measures of all the illness domains and optimize the instruments and the scoring and correlate them with biologic measures. But we can't do that alone. And so we joined to develop the common data elements with ME/CFS with NIH. And Vicki will tell you a lot more about this project. And but basically, I just want to emphasize the importance of these common data elements, which are not a database, but they are ways to actually measure the illness so that we have more than just a simple case definition. We have the full range. And with that, I would like to close and thank you very much for your attention and thank the group at CDC and the patients that we work with.